Good afternoon, everyone. Welcome to the 2022 Recovery Summit and today's presentation, Understanding Substance Use Disorder Diagnosis in Adults and in Youth and How to Help. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube account for any future reference and viewing. Please feel free at any time to go ahead and use the chat box at the bottom of your screen. That's for any questions and for comments you have during this webinar. And if time allows, at the end, we'll answer as many questions as we can at the conclusion of the presentation. We also wanted to do a general reminder for anyone that is tuning in that if you are requesting any professional continuing education credits or a certificate, it is absolutely imperative that you remain on the webinar till the absolute end. So again, just to repeat, please don't sign off early or a few minutes early. Please make sure you sign in and stay into the webinar to the very conclusion if you're requesting a certificate or a continuing education credit. So it will show on our report in order to give you credit. We appreciate that. So on with our presentation today. Our presentation today and our presenter is Ken Huvelman. Ken is a clinical coordinator and outpatient therapist with Odyssey House, Port Huron. He has worked in the behavioral health fields for more than 8 years, including outpatient substance use services and inpatient psychiatric care. He holds a master's degree in psychology from Montana State University Billings and a master's degree in clinical mental health counseling from Walden University. Additionally, he has worked as a consultant with MDHHS and other organizations to advocate for the expansion of access to behavioral health treatment and for the innovative approaches to reduce the community impact of opioid overdose. And with that, I'd like to turn it over to Ken.
Sounds so professional. It better says he just shows up and does stuff. Thank you for that. Welcome this morning. Let me go ahead and get my screen shared up. I appreciate everyone that has registered and signed in. I am seeing a little bit that might be some audio issues. If you're continuing to not hear, go ahead, place that in the chat and we'll see if we have to work something out. All right, so as identified, this is understanding substance use disorder and then ways in which you can help. Some of the help resources are navigated towards St. Clair County in general, just because it is a St. Clair County CMH presentation, but some of the statements kind of fit collectively. Taking a quick look at the numbers for substance use disorder as a state compared to our nation as a whole is we're a little bit above average or right about at average. We do have higher, as you can see, for cannabis use disorder, alcohol use disorder, and just a tick under for opioid use disorder. So this is a total number of population that is diagnosed with this disorder. So if you add all of those up, you're looking at about 8.4%, I think it is, or 8.2, have a diagnosis. Nationally, those numbers, like I said, about the same. So when using diagnosis, there is the DSM-5. I believe now they just came out with the DSM-5-TR. That is the Diagnostics and Statistical Manual of Mental Disorders, and I'm going to get that wrong. And that is the book of diagnosis. Any mental health, behavioral health diagnosis is going to come out of that book and that classification system. For the substance-related and addictive disorders, it did identify 10 different classes of drugs and then just one behavioral. As you can see on there, caffeine. Caffeine is the only substance that's listed in the DSM that doesn't qualify for a use disorder, just caffeine intoxication. And that's often is something that is relating to another disorder, very often anxiety disorders, or sometimes other mental health disorders as well. It does also have a withdrawal diagnosis for caffeine. The other one that is interesting of note is it used tobacco. So when they wrote the DSM-5, this was 2013, they used tobacco. So if you're going on a technicality, which anyone that knows how my head works, unfortunately, that's how it works. It doesn't fit vaping because vaping is a nicotine product. This fits tobacco. I believe in most cases, and most people I've chatted with, it's not a common diagnosis to get somebody to treatment. There's usually something else co-occurring with it, but it is usually stretched to cover nicotine. The other behavioral one, as I mentioned, is gambling disorder down there at the bottom right. Gambling disorder was the only behavioral one because of a lack of peer-reviewed research on any of the other common behavioral addictions or process addictions like sex, shopping, internet. I believe video gaming was considered. So they had considerations of other behavioral addictions, but none of those had enough research to be included in the DSM-5. As you can see, the other common ones: alcohol, cannabis, hallucinogens, sedatives, hypnotics, and anxiolytics. That fits your benzodiazepines as well. And then other substances, the common one that falls in there might be like an anabolic steroids or other non-controlled substances that people just tend to use in addictive ways. So in order to meet that threshold for a use disorder, that this person has a use disorder, and it's a term that we use more commonly. It is becoming kind of a social justice mention. We get rid of the words alcoholic, addict, in those phrases, and we consider it a use disorder. It is a person with a use disorder to keep that person first language. The biggest chunk in that is it says there is a pattern of alcohol use, and that can actually be alcohol, cannabis, any of the substances. I think in some of these slides, I do use alcohol as the word that's in there, but replace that with whatever substance of issue. That big part leading to clinically significant impairment or distress occurring within a 12-month period. So if it's not really causing too much of an issue, if it's not meeting that threshold, then it's not actually diagnosable. The other one that is the catch is that's occurring within a 12-month period. That doesn't say occurring within the last 12 months. And this is sometimes a discussion of debate. When does a use disorder come off? If a person has a cocaine use disorder that was in the early 2000s and they haven't used cocaine and it's been 15 years, do I still consider that as an actual active diagnosis if we're that far down the road and they're coming into my office today for a cannabis use disorder? That's still up for debate with most people I talk to. Usually there's at some point, it's a belief that it falls off. But that is that, so that problematic pattern of use within a 12-month period. These first four criteria, the way to look at criteria is 1 through 4. We break them into groups. This group can be considered impaired control. So we're looking at the person's ability to manage their own use. This is where they've, the locus of control is outside of them. So we've got substance taken in larger amounts for longer than intended. This may be the person that planned on drinking a couple beers over the weekend turned into Monday. The weekend started on Thursday, then Friday, then Saturday, then Sunday. Or I just wanted to have a couple glasses of wine, and a couple glasses of wine turned into a couple bottles. So that's large amounts, longer than intended. Then we have that effort to that hard effort to control. Whether or not there's been successful or unsuccessful efforts to cut down or control their use. You know what? I'm not going to drink for the next 30 days. I'm not going to smoke any pot. I'm going to just do nothing. And they make it about 4 days. This is also the continual relapse. So this might be a person that gets 3 months. They might get a year, but they continually run into this issue where they keep having unsuccessful efforts to control that use. This one is another one that can be, it's a little bit open. Great deal of time spent to obtain, use, or recover from substance use. Does the person spend a couple hours a day of what could be otherwise productive time seeking out the substance? Some of these, it shifts. If it's alcohol, it's a lot easier to seek out. You can go to a store, you can go to a restaurant, you can get the alcohol much easier. Some of our other substances, such as methamphetamine, opiates, fentanyl, things like that, there's a lot of time that the person may have to put in just to get it. just to find the drugs that may be a portion of their day. This might also be the amount of time it takes to obtain funds to purchase the drugs for the day or what they plan to use for the day. So maybe 3, 4, 5 hours a day is just spent trying to get the substance. Then we have that part where use. Is this a person who, when they wake up, they start using, then they have to use at lunch to keep it going, then they have the afternoon break, then they take the safety break at the end of the day, and they're using again. And that they are continually having to pattern their life around use. This can happen in a blue collar world, white collar world, or any of those parts. What happens often with that one is you'll see people planning business lunches or meetings at places that serve alcohol. If it doesn't serve alcohol, they're not meeting there. I'm not having a business discussion. I'm not closing on a deal at Tim Hortons. I need to go to a restaurant that serves alcohol. They will start to move their day around so that they can obtain and use their substance. I don't want to go too far without being able to get my next shot or my next drink or my next use. Then recovery from substance use. You can see the memes anywhere that, and I see them all over social medias that I use that talk about, drinking in your 20s and you wake up and you're fine, drinking in your 30s or 40s and the hangovers are worse. Well, part of that might be to continued use. So your hangovers might be becoming more and more problematic due to tolerance, due to increased use, or it just might be that downtime that it takes for a person to recover. So if you lose a day of productivity or you're just thrown off for a day or two, it's a great deal of time spent just to recover from using. For some of the hallucinogens or some of those festival type drugs that people talk about, if you need a day to come down, if you need a day break from your use, that's probably of concern. That other part in the impaired control, we've got cravings, strong urges to use. This is the person that talks about a preoccupation with it, that's all they think about. They wake up and they think about their drink, they wake up and they think about their next shot. They think about, when they're going to get to smoke it. As soon as I get off work, I'm going to be able to go here and get it. And it's that craving and strong urge just persists with the person throughout the day. So again, these first 4 criteria, and there's 12 criteria total for a substance use disorder. So we've met with a person, we're starting to get this history of them. We're starting to look 1 through 12, which ones do you meet? Hang on, check it, check it, check it, check it. Okay. So these first 4, we're looking at impaired control, whether or not the person has the ability to rein in and manage their own use. That can reflect into kind of a 12-step program, I believe, and I am not a 12-step member. I am a addictions counselor. Believe that kind of covers step 1, 2, and maybe 3, is that ability to use. So it does mirror a lot of the recovery programs, do actually mirror sometimes the diagnosis. Our next set of criteria, this is 5, 6, and 7. This is its social impairment. What level of social impairment exists with your use? And again, these can drastically shift. Some of these are a little bit trickier with some of the substances because they're just socially more accepted. This is very common with the cannabis and the alcohol because they're just there. They are just part of many people's everyday social life. So these ones can get skewed or are sometimes a little trickier to identify. So you got the recurrent use resulting in a failure to fill work, school, home. And a lot of times those are the big 3 for any mental health or behavioral health diagnosis is what impact does it have on work, school, or home? Because those are most of our domains. That's where most of us exist. We have, most have work, and if it's interfering with the ability to do that, most of us have obligations at home, even if it's our own home, even if you're a single adult, you have obligations at home of your ability to, keep a tidy or clean to you level of living. Is this interfering with this? Is this, you just have all these things interfered? Does it interfere with school? School, of course, can be for adolescents. It can be for adults. So you look at the college person, their ability to make it to class. The old jokes that you don't schedule classes before 9 o'clock, or you make sure you have Fridays off because Thursdays are thirsty. And those things, we normalize it. It's sometimes because it's socially acceptable. Other situations, it's ostracized because it's less socially acceptable. So we have that inability to maintain your basic responsibilities. Then we're moving into continued use despite social or interpersonal problems. And I'm probably going to keep defaulting back to alcohol use as a lot of my examples. It is the most common. As you saw, 5.8, I believe it was 5.8% of Michiganders have that as a substance use disorder. Alcohol is still the number one admission substance for those seeking treatment outside of the Region 10 area. So in most of Michigan, probably the US, alcohol is at one. So if my examples fall to that, that's just kind of where I think I go. But it obviously applies to opiates, to methamphetamine, to inhalants, to hallucinogens, all of those kind of the same. I just often you'll hear me using that alcohol that viewpoint. So this is that person where, they go out and their liquor doesn't agree with them. They tend to go out, and every time they go out, the old allergy is they break out in silver bracelets. They get in bar fights. They create continued issues within their personal relationships. They may be the most loyal person, then they drink too much, and then all bets are off. So this is continued use. You see that this is causing issues. You maybe had a divorce. Your friends don't invite you over as much. You're having persistent and recurrent social and interpersonal problems, either caused by your use or your use makes it worse. This is the person who begins to use methamphetamine and then starts to isolate. They shut off everyone that they used to hang out with, that friend that you used to know that has drifted and doesn't leave home or just is stuck. And the person might recognize that this happened. The client or patient may not recognize that this has happened, but it's this greater problem caused by your substance use. We think it's no big deal, but then we stop and we look and go, holy cow, where'd everybody go? The other one is that we start to give up or reduce social, occupational, recreational. Again, we don't go out and do anything. We don't hang out with anyone. We don't have time because I'm married to the bottle. I am married to, Lady H or whatever those phrases come from. And they're that because they do. The phrases that they'll hook your claws into you and pull you away from everything. Yes. That's what we're seeing. That is a diagnostic criteria that these people are starting to give up things that were once important to you. Real easy question on this one. You're sitting with a client, you're sitting with a person, ask them what they do as a hobby. In a person with lived experience, I was asked that question. I paused and I went, it's a good question. I don't know what I do. I didn't have a good answer, or I gave an answer and they said, when's the last time you did it? And I realized I hadn't done it for 3 years. That was something I identified as a social and recreational activity that gave me pleasure. And I gave it up because other things got in the way. And I didn't even recognize it. And it was one of those simple that it just takes all the things from us and we don't even notice it. It's that time passes and you realize you haven't done it in a long time. Being in the blue water area, this is people that say they love to go fishing, but haven't gone. Occupational. The old saying, and I might butcher this, was the difference between an alcoholic and a heavy drinker was that if drinking interferes with work, you're a heavy drinker. If work interferes with drinking, you're an alcoholic. And it is that shift where I can come in hungover, but when work starts to interfere where, I can't make it 4 hours without a drink and I got to be at this stupid job. So I start to give this stuff up. It's not as important. I'll figure out money in a different way. I've worked with clients that have talked about their 401k that existed. That's why they didn't have to go back to work. They drained their retirement accounts because methamphetamine, stimulant, cocaine use interfered with it. So with this one, we're looking at social impairment. How much is this hurting the person's quality of life? So we've got impaired control. You think you know what you're doing, but it's got you. Social impairment. Your quality of life is just fading away. And again, some of those are tricky because quality of life. I don't have interpersonal problems. My life gets better because I drink. I only hang out with people when we smoke, marijuana. So it starts to be sometimes some of those are trickier. Cannabis is sometimes one of the harder ones to nail down because it often doesn't have as many negative impacts in that social impairment. It also doesn't come with a lot of people in the reduction of use because some people may just have used it the same amount for a long time. So it's tricky to get some of these. Like I said, you'll get clients and you'll get a person you're working with sometimes that you see and you're like, yes, checking the boxes. These are clear. Sometimes not so much. So criteria 8 and 9 out of the DSM are recurrent or risky use issues. Is there a risk factor just in or how you use whatever substance you use? So recurrent substance use in situations which it is physically hazardous. Easiest one to see for this is you have a client in your office with a DUI. Well, we can agree that it's physically hazardous to drive a vehicle under the influence of a substance. Easiest checkbox is when you get a probation referral, they have a DUI. Well, we have that criteria. But this can come into other situations. It's common for situations where people become too intoxicated and are unable to consent to sexual activity. And that's physically hazardous, that you drank to a point where you were unable to respond or prevent yourself from having a physical, sexual, or some other sort of assault happening to you. This is the person that continually drinks and makes sure that they fight anyone in the bar. This is those situations where your continued use, you're putting yourself in physically hazardous situations. The person who's had multiple overdoses on a fentanyl or an opioid, if you've continually overdosed, you are placing yourself in that physically hazardous situation. The use of unclean syringes, physically hazardous. You're at risk for HIV, hepatitis, skin infections. So is the nature of your use making you physically vulnerable? Could bad things happen just because of where you're using, and do you just dismiss it? This is the person that goes down to the city of Detroit and uses an abandoned house. They go to somewhere, anywhere, and so I guess that was, sorry. I will apologize to the city of Detroit because there's lots of vacant homes in lots of places that people use that's physically hazardous. It is not unique to Detroit there. But this is that situation where it's a flop house or a home where everyone just goes and uses. That's physically hazardous. Your safety is not good, and a lot of people in the throes of addiction or whatever you want to phrase it, that's normal. That's just how it is. You go and you use somewhere. You go and you sleep outside in December because it's just what makes sense because that's your life. Physically hazardous. The other part of the risky use is continued use despite knowledge of having a recurring or persistent physical or psychological problem either caused or made worse by the substance. If you have depression and you drink, that's a psychological problem, possibly caused by, but most likely exacerbated by the use of alcohol. ADHD and self-medication. You have diabetes and you continue to drink alcohol at a high clip is a good way to start to lose some of your ability to count to 20. It just is these things. You may have been in liver failure. You may have been hospitalized for these issues. And then once you get the all clear from a doctor, you're back to drinking. Individuals who I've worked with that are on liver transplant lists that get a liver and then determine how much that one can filter out the alcohol of the next one. It is things that happen. This is kind of falls into that impaired control part. Like, that your continued use of this is likely to make life worse. It's going to exacerbate your physical or psychological problems. Life is going to get worse if you continue to use, but because there is such a change within you, it doesn't matter. You're going to continue to use despite knowledge of having this problem made worse or made by. This is, that disbelief that it matters. This is that just kind of cognitive dissonance that it's not clicking. So we've got risky use is another one of those groups. Jumping into the last two, these are known as the pharmacological group, is their tolerance. Tolerance is that need for more, increasingly, markedly increased amounts. I love the big words of the DSM. More of the substance to achieve intoxication or the desired effect. I used to drink a 6-pack. Now I need to drink a 12-pack. I switched from beer to liquor. I used to take a Vicodin. That doesn't work. So now I snort heroin. Heroin's no longer cutting it. So I went to the fentanyl. Do you need more to have that same effect? The other part is that there's a diminished effect with continued use of the same amount. So maybe they don't change. Maybe this is the person that continually smokes one joint a day. But that one joint a day, they still feel that they can move about the day more easily. They don't feel stoned after one joint. I've got to have 2, 3, and then I might start to feel a buzz. But one, that's no big deal. That's just getting started. This is the person that can drink the 6-pack and you don't notice that they just drank 6 beers in a couple hours. They might not increase and keep drinking, but there's that diminished impact or effect with continued use of that same amount. Medications can be this way. You continue to use, the same amount of morphine, and it's not touching the pain. I am still feeling withdrawal. I'm still not hitting what I want. So for the last two, we're looking at tolerance. And then the other is withdrawal. Is there a identified withdrawal from that specific substance? So the characteristic withdrawal of the specific substance, withdrawal will be different based on the different substance use. Alcohol withdrawal is different than withdrawal from opiates, which is different from a lack of tobacco. The other one is there a substance or closely related one taken to relieve or avoid withdrawal symptoms? I think we've heard this one called hair of the dog. This is the person who is starting to go into withdrawal. They don't want to take any more heroin, or they don't have it, so they take an opioid. They know that they're going to get sick, but a Suboxone will tide them over to the next time they can get it. This is the person who would prefer to have cocaine or methamphetamine, but they'll make a Ritalin or Adderall make do for today. So I know it's going to be a rough day. Let me have this one. I'm trying to think in the tobacco world where this fits. It's probably less common. It may be the person that doesn't have a cigarette, so they're going to put in a dip. I think it's been years since I've watched that substitution. But it kind of is that I'm looking for something close enough. I might not be able to get what I want, but this will keep me from feeling bad. One of the interesting ones that I remember learning, and it was kind of one of those surprise factors, is a hangover is not something generally recognized as withdrawal, but that's what it is. It is acute, mild withdrawal. That is the headache, the nausea, the photosensitivity, all of those symptoms that come with a hangover. That's withdrawal. If you are drinking with a higher tolerance, then you're going to have in the more severe. So sometimes if you can catch a client it catches the wrong phrase, but if you're trying to identify a client and help them understand the concerns, because this sometimes is that motivational enhancement. Well, I don't really have a drinking problem. I didn't check a lot of these boxes. Do you ever have hangovers? Oh yeah, I get the worst one or this. Okay, well, that's withdrawal. And sometimes in that lower level of care, that's that early intervention. helping someone understand that hangover is, as your body going through withdrawal, it wants more, which is why hair of the dog or having a drink in the morning afterwards can cease the withdrawal symptoms. So those 11 criteria, those are the basics that are there. Those are what you have to have. If you're going to get diagnosed with an SUD disorder, you have to have at least 2 of those. So you got the impaired control section, the social impairment, risky use, and pharmacological. Out of all of those, if the person only meets 2 or 3 criteria, then it would be a substance use disorder mild. So using alcohol, again, that would be an alcohol use disorder with a mild specifier. The next one up, if they've got 4 to 5, now it's a alcohol use disorder moderate. And then severe is if they're meeting 6 or more. Prior to 2013, when they used the DSM-4 in the past, it was identified as alcohol use, alcohol abuse, alcohol dependence. Those phrases went out, and it was just kind of this scale of mild, moderate, severe. I really think this works a little better for helping a person understand and demonstrate the significance of their diagnosis to them. So when I'm explaining it, I think most people are going to get mild, moderate, severe, use, abuse, dependence, kind of clinical. Another caveat in diagnosis is, so you have a person that come in your office, you start working with them. They have an alcohol use disorder, severe. We'll give it a severe. At some point, they get the benefit of remission. They've made successful strides. They've started to maintain abstinence. 6 to 11 months of abstinence is considered in early remission. So you'd have an alcohol use disorder, severe, in early remission. If they've got it for greater than 1 year of abstinence, it's in sustained remission. So that kind of falls to that discussion I mentioned at the start is, this is within a 12-month time frame, but we're talking about the 12 months between January 2001 and December 2001. Sure, I met the requirements for an alcohol use disorder severe in sustained remission. Do I keep that going with them in their chart for the next 21 years using that specifier in sustained remission? This kind of allowed it to fit in there. Previously, these remission specifiers didn't exist. So you had an alcohol use disorder. In the past, you had alcohol use or alcohol dependence, and it stayed with you. If it stays with you, the use of these specifiers, I believe, is crucial and important. If I walk in and see a person who's got an alcohol use disorder, that immediately tells me that they've got less than 6 months without using. If I see it with some sort of remission, I then know that I'm working with someone in a slightly different capacity. This person has been able to put together a length of abstinence and is starting to become successful in their long-term recovery. That's going to reach a different level of treatment planning, different level of care, different level of navigation for that. So you've got those 12 criteria. You count how many did they meet. And sometimes, when you first start doing the diagnosis, like any other, it just takes some consultation with a clinical supervisor or someone else. I'm struggling. Are they 2? Are they have 3? Is this moderate? Is it severe? What do they meet? And it's one of those, as you do more and more, it starts to make a little more sense. In the nature of time, I'm going to push through this one a little bit quick. This originally was, I believe, a 90-minute to 2-hour session. I'm not going to make you listen to me that long today. This is your common neurotransmitters in the brain. This is what drugs work on. This is where they go. This is what they affect. Your common one is so if we start from the top left and go across, we've got adrenaline, which is your fight or flight, your heightened awareness. Stimulants bringing it up, depressants and opioids bringing it down. So this is that fight or flight. Noradrenaline, that's your concentration neurotransmitter. That's attention, concentration, one of those that is often impacted by stimulants. Dopamine. Dopamine is your basic pleasure and motivation. This is what makes you want to do anything. Dopamine is probably the one that's getting messed with the most with any person with any level of substance use disorder. From my understanding, this is the one where it's really starting to get messed with. Cocaine, methamphetamine, other stimulants really mess with this one. You get the flood of dopamine, and then you go below the basement or below the floor, and the person actually has a deficit of dopamine, which can lead to that anhedonia in early issues with early recovery. It's pleasure and motivation, serotonin, another very well and common known one, emotional well-being. This is your sleep cycle. So again, if we have the stimulants, these are getting thrown off. It's a mood neurotransmitter. The sleep cycle, many people, this is one that I always found interesting. We've heard of tryptophan. Tryptophan breaks down into serotonin. Serotonin breaks down into melatonin, which then is that part is how and why we feel sleepy. So go to Thanksgiving dinner, eat too much, double check you didn't get a use disorder for eating. Then we're going to push over to the binge eating disorder, but Thanksgiving doesn't count. This is that part. It's connected to that. Another interesting one about serotonin and a little bit with dopamine is it's connected to exercise. If you want to help a person reestablish the healthy levels of dopamine and serotonin, exercise. Tell them that they should go to the gym. They should try running a 5K, maybe sign up for the Run for Recovery coming up next. I want to say May. I'm not positive on that one. It might be October. But pushing someone towards exercise actually can help reestablish a healthy level of neurotransmitters. Also tell a person who is trying to quit using drugs and alcohol in early recovery, they should go work out, and they might flip you off because it sounds awful. GABA is another neurotransmitter. This is the one about calming, inhibition, high levels is focus. So if there's high GABA, you are overly focused. If there's low levels, that's when we start to have anxiety, which is why GABA inhibitors start to lead to alcohol or that lack of inhibition. And then motor control. GABA is also in the part for motor. Acetylcholine, learning and memory, muscle actions. So this is that ability to activate muscles and then attention and awakening. Glutamate, learning and memory, regulate development and creation of new nerve contacts. So this is your building block. This is the one that is necessary for brain repair. And then endorphins, these are another one that are spiked in the euphoria of drug use. Euphoria and well-being often comes from sex, exercise, and excitement, and then works to bring down pain. So looking at those substances, this is kind of where they go. This is what they're going to hit you on. This is your dopamine pathway. Anything that's bringing you that pleasure, anything that is motivating you to carry on and keep going, this is that pathway. They move through the brain, they hit the same areas, and they function in that same method. Some are going to have an up, some will be a down, some will flood it, some will make it a little bit inhibited, but really everything's moving through this region. So looking at a quick explanation of the different substances, most of us are going to know a lot of this. Alcohol, we know that someone is probably using alcohol because there's a behavioral change, shifts in mood, and it can be in either direction. They may be a happy person. Shortly thereafter, they may not be so happy, and there's now tears in the beers. Impaired judgment, slurred speech, incoordination, signs of intoxication, withdrawal, sweating, headaches, insomnia, anxiety, a seizure, alcohol in that GABA relationship. Alcohol withdrawal is potentially lethal. Alcohol withdrawal is the one that needs to be taken very seriously. To do so on one's own is not advised. I've worked with clients where I said you can either go to a detox, but if you start to, shake or lose it, your options are to either call the ambulance or call your local bar. Because if you continue to detox it, it may lead and be lethal. Cannabis, marijuana, intoxication is your motor coordination's impairment. It can lead to anxiety in higher doses, social withdrawal, red eyes, dry mouth, increased appetite, perceptual disturbances, especially with high levels of potency, with wax, dabs, or other forms of cannabis beyond just the flower. Withdrawal symptoms, most people tell you they don't have withdrawal from cannabis, similar to tobacco. Irritability, aggression, anxiety, issues with sleep, restlessness, and a depressed mood. So more so in the psychological than the physiological, more just feeling distress and uncomfortable, no lethal issues with it. Opioids, intoxication looks like apathy, constricted pupils, drowsiness, often known as nodding off, where a person feels like they're falling asleep every 12 seconds just to wake up and act attentive to fall back asleep. Slurred speech, attention impairment, they're there, but they're not quite there. They seem distant or they fade in and out of being present. Withdrawal symptoms, dysphoria, really low negative mood and feeling, nausea, muscle aches, fever, insomnia. It's often referred to as getting the flu and also being hit by a truck at the same time. The other common statement is most people going through opioid withdrawals wish it could end lethally or wish that it would just stop, but it is not lethal. It's often managed with comfort meds such as Suboxone or other milder or lower potency opiates. Stimulants. So, I believe stimulants, I think in this slide, I do include cocaine, caffeine, and methamphetamine because those are all in that same class. They are separate use disorders, but they are in the stimulant class of drugs. We're looking at restlessness, anxiety, anger. You see weight loss, irregular heartbeats. Withdrawal is, again, that dysphoria. For the stimulant population, there is no real detox. Often people with a stimulant use disorder are put right into treatment, despite a desire to have a couple days to reset. Insomnia, increased appetite, and then that fatigue. So that kind of gives that synopsis of what's a diagnosis look like? What are we looking for? What determines how significant, severe, or where this person's problem is? We're looking at the control. Can they control their use? Can they navigate life while using? Is everything about their youth making everything about their life that much worse? Now that you know what you're looking for or that you're dealing with it, or yes, it looks like a substance use disorder, how do you help the person? What's available? If you're a professional or a family member, the best and basic things you can do is educate yourself about addiction or use disorders and recovery. What exists? What's out there? Offer your emotional and social support. Notice there is not a financial support. It is not recommended to give a person with a use disorder and early recovery money because it might not go towards what they said it would go. Sometimes it is offering things. If they say that they needed cigarettes, buy them cigarettes. If they said that they needed food, buy them food. Cash magically transforms into multiple things quickly. Instill an internal desire to change. Just because you want them to change doesn't mean they do. So how do I help that person want to change within themselves? How do I help them see that stopping their use will make their life improve? How do I help them see that? Because if they don't see that, they're not going to change. That is you can do it for your wife, you can do it for your job, you can do it for the courts. But until you do it for yourself, it doesn't work. And that's a very big statement. And a person can start external motivated and become internally motivated over time. Another part is to understand that recovery is a process. Recovery is a lifestyle. It is a choice. Once you start recovery, if you plan to remain in it, that's forever. Recovery takes a while. We look at people sometimes that have a year clean, and that's amazing. A year off of drugs and alcohol is amazing. But in the grand scheme of it, sometimes you really haven't scratched the surface. 3 years, 4 years, 10 years, 20 years in, you're still learning, you're still growing. This recovery process is something that takes a while. That's for self and for others to remember, and to help them remember that it's going to be a little bit. It's going to take some time. If you're going to be helping someone with a substance use disorder, make sure you take care of yourself. This is the old airplane, put on your mask before helping someone put on theirs. Because if you go down, you're no help. Self-care, boundaries, setting that limit on how much I can do for the other person is absolutely important. If you don't take care of yourself, you just can't help someone else. This is a professional. This is as a family member. This is as a friend. You have to have you as a focus. And if you can't give it, then they can't get it from you. Encourage them to get help. Don't force them. Don't tell them. Recommend it. Do you think it would hurt to talk to a counselor? Hey, have you thought about trying a meeting? And if they say no, say, okay, maybe we can try something else. What else might benefit you? What do you think could help? So that's that encourage. It doesn't say yell at them until they get help. It doesn't say tell them where they have to go or you're leaving. It doesn't say the ultimatums. At times, these might be the situation within your relationship that, yes, in order to take care of yourself, we have to go apart. But that's a whole separate decision. The basics is be educated, offer support, understanding, and compassion, and help them know that they need help. So this is a little bit local to St. Clair County. These are recovery support programs. Some of these are recovery community organizations. These are programs that are for recovery. This is for people that have entered into a phase where they have decided they're going to stop using drugs and alcohol. Locally, we have BW Rock, the Recovery and Outreach Center. They're a recovery community organization providing coaching and other services. There is Families Against Narcotics. I am not positive that the Blue Water chapter is still active, but across the state of Michigan, there are multiple chapters of Families Against Narcotics. This is a shared meeting space that allows a community-based program for those seeking recovery, those in recovery, and for family members of those affected by addiction. Then you have the Blue Water Area Narcotics Anonymous. That's the NA 12-step program. Most regions across the state, you can find a meeting generally within a dozen or so miles at the furthest. The other is Alcoholics Anonymous. We're District 23 here in the Blue Water area. Then there are a couple others like Smart Recovery, Celebrate Recovery, and Refuge Recovery. Smart Recovery is self-management and recovery training. The approach is secular and science-based, using cognitive behavioral therapy and non-confrontational motivational methods. Celebrate Recovery is a Christ-centered 12-step recovery program for anyone struggling with hurt, pain, or addiction of any kind. And then Refuge Recovery is a Buddhist-oriented, non-theistic recovery program that uses a traditional formulation consisting of the Four Noble Truths and the Eightfold Path. So you run into people that says, I don't know what works. I don't do meetings. Okay. 3 other options that do or have existed within the Blue Water area. I don't know about the Smart. I do believe there's a Refuge Recovery or one very similar. There's also a Celebrate Recovery. So there's alternatives to where a person could go without feeling that they formally went to treatment. They just need community or recovery support. Treatment is something different. If you've been at any of my webinars in the last couple of years, has been kind of helping people understand what is treatment. For those in Genesee, St. Clair, Sanilac, or Lapeer County, that is the Region 10 access line. If you need publicly funded services, or possibly if you're on a commercial or uninsured, you call that Region 10 access line. They will screen you. They will get you an intake to what you need. They'll tell you what probably would be of most benefit for you. That's that 888-225-4447. The organization I work for, Port Huron Odyssey House, we are an outpatient and recovery housing. CMH. CMH has co-occurring, has SUD only, has mental health services. Sacred Heart is a residential and outpatient and medication-assisted treatment provider in the Blue Water area, as is Meridian Health Services. A couple outpatient providers within our community are also Renewal Christian Counseling, the Professional Counseling Center, and then Catholic Charities of Southeast Michigan. So any of these places would be formal treatment. This is where you're going to have a counselor, you're going to have a therapist, you're going to have an addiction professional. Professional help is that it's detox. It's a residential treatment center where you're going for 28 days, 34 days, 18 months. There's short-term residential, long-term residential. Detox is withdrawal management. This may be a few days. Sometimes people will leave detox to residential, to IOP or intensive outpatient, to outpatient. Some will go to detox and not do anything else. Some will detox to outpatient. There's a whole hour webinar available on the CMH YouTube page where you can learn all about that from previous recovery summits. That's a quick self-pitch for my old webinars. But detox, residential, intensive outpatient, these are different levels of care depending on the severity of the use disorder. Addiction professionals are credentialed. They're not necessarily licensed. You can be a bachelor's or an associate's or a high school diploma level or a master's level addictions counselor. So there's the certified alcohol and drug counselor. And then at the master's level is a certified advanced alcohol and drug counselor, which means there's a greater understanding of mental health and co-occurring conditions. And that's McBAP that does the addiction professionals. A licensed master social worker, licensed professional counselor, licensed psychologist are still people that can treat and work with a person with SUD, with that substance use disorder. But if they've got those letters after the CA or the CAADC, it does mean that they've reached a different threshold of understanding and working with those with a substance use disorder. Another quick spot to touch on as we wrap up here for our hour is that how can I help? And it's looking at social justice and substance use disorder. That purple, or purple, not purple focused, people focused care. That's to reduce the stigma, using terms like those people, addict or alcoholic. And you can have debates over those all the time. Similar to personal pronouns, how a person prefers to be referred to. I have met people that want to be called an alcoholic. Others would rather say they have an alcohol use disorder or they're a person with a drinking problem. Some people don't find it to be stigmatizing to be known as an addict. Some people may say I have lived experience. They may say I'm a person in recovery. Then there's another part of semantics, sober, clean, recovery. Those terminologies can vary depending on the affiliation or recovery program you're in, that people can have strong statements towards any of those words. In my personal opinion, the word recovery is more inclusive and covers those that are on multiple or different pathways. Because recovery is not always abstinence. Recovery is a process where a person pursues remission and may have met and resolved some of the issues, but may still use a substance that isn't part of another program. Harm reduction, syringe service programs, using Clean Works, supporting naloxone and things like that can help, is another way that you can help individuals with an SUD. Supporting medication-assisted treatment and access to it. If you are a person on methadone in St. Clair County, you have to travel out of county at least a half hour on your own once a day to go get your medication in order to not enter into highly unpleasant withdrawals. Very, very few other medications do we not put local? Imagine if the pharmacies were all 45 minutes away and you had to get a ride to a pharmacy daily to pick up the medication you've been on for the last year. So supporting access to and availability of medication-assisted treatment, and then also being open to people who are on that method of recovery. If that's their chosen plan, we support them. Another position is the decriminalization of all drugs. This would allow for a different stance instead of arresting. This is a compassionate and more open method that these people aren't necessarily in there. See, I said these people with a substance use disorder aren't necessarily criminals. They aren't necessarily the scourge of society. They are people with a substance use disorder that would benefit from something other than criminalization. I think so. References for this for the National Institute of Alcohol Abuse and Alcoholism, obviously from the APA for the DSM, and then SAMHSA for some of those statistics. I don't know if there are any questions. I see that there's a lot of stuff in the chat, but I don't know if any of those are there. So I don't know if Adrian's still here.
I am still here, Ken. Thanks. We do have a couple of questions. So I'm going to start out with the first one. How do you address a loved one that insists they can achieve recovery by themselves?
It's really that support, because again, we want to look at making it internal. If that person believes they can. What we do a lot of with individuals who need motivation to get treatment. So if I'm dealing with a client who struggles to see that it's not working, it's sometimes delicately pointing out contradictions in their story. If you were able to maintain abstinence by yourself, why do we keep drinking? Like, it's not working. So it's that soft encourager. You're trying. I absolutely believe that, you can do this, but I think sometimes a little bit of help might be beneficial. So really softening that part to push them to, it's just not working on your own. If you're building a house and you only put up 3 walls and you try it again and there's still only 3 walls, at what point do you call a builder? These are people who are trained in it, who know how to do it, and are there to help you push through it. So it's a soft encouragement, trying not to punish them or make them feel like a failure for not doing it. That's a pride thing. I should be able to take care of my own business, and if I can't, I failed. So a lot of times it is tough to walk into a clinic.
Okay, thanks, Ken. Another question is asking, when seeking counseling, is it best to look for someone who has lived life experience with a history of use or difficulties?
No, but probably doesn't hurt. It doesn't require lived experience. Sometimes people who have no lived experience have knowledge, skills, and abilities that others don't. A lot of people seeking recovery services want someone that gets it, that understands the full way that a substance use disorder can derail a life. I have met some wonderful counselors who didn't necessarily have the substance use disorder themselves, but you can believe that a close family member generally did. So that person wasn't a person in recovery, but they have experience in living and dealing with people are. So is it an absolute requirement? No. Does it seem to be common to relate to a person with lived experience in the addiction world? Yes. It just is more common, and it does seem to cause buy-in, but I've worked with great counselors who have no personal experience with a use disorder.
All right, Ken, that's great. And just because time's winding down, we do have additional questions that we're not able to get to, but we really want to say thank you to everyone that did submit questions. So we're going to go ahead and wrap up. If you want to wrap up with anything, Ken, and then we'll conclude the webinar today.
I don't have much else other than just to thank you. And like I said, I have a previous couple that CMH, the St. Clair County CMH YouTube page is wonderful for all the previous Recovery Summit presentations you've seen. So there's good info there.
Fantastic. Thank you so much, Ken, for your presentation, all the information. There were a lot of people that asked about the PowerPoint, and it is actually up on our sccmh.org website as of right now. If you go under the events tab where you find all the information on the Recovery Summit, you can go ahead and go down to the Recovery Summit and find Ken's PowerPoint there. So a lot of requests for that. Ken. So thank you again, Ken. Thanks for everyone that attended the session today. Just to recap, today's presentation is one of many webinars. I believe we still have 15 more to go for the month of September. You can still register for any upcoming presentation at sccmh.org. I believe tomorrow's presentation, which is September 8th, is starting at 1 o'clock. It's neoplastic pain, a new name for an old type of pain. And on Friday, our presentation starts at 9 a.m. and it's medication for the treatment of opioid use disorder with Dr. Janice Romanek. So thanks again for joining us today, everyone. We look forward to seeing you at the next webinar. Have a fantastic day.